Before I start, I feel a great need to publicly acknowledge Grace Leo and her assistance with this presentation. I don't know that Grace will have had any sleep in the last 2 weeks as she's helped all of us with our talks. Because the theme of the conference is about storytelling and science, I do want to tell a brief story at the beginning, so this is not related to the literature, but I wanted to talk about it because it's something that happened in our children's ward in the last week, and we had a most awesome week. And I want to encourage other units to go away and think about doing it. So a few months ago, someone came up with the idea, well, they do party day up in the children's hospitals in Sydney. Why can't we do party day down here? And so we decided to have party week. We went for the week because doing it for the day ran the risk that we might have picked a day where the ward was only half full. We all know about fluctuating occupancy in paediatrics. So we went for the whole week, culminating in the party day on the Friday. We decorated the ward, turned it into a magical kingdom for the week. The staff came dressed up every day, various themes. The schoolroom became a dungeon. We had witches, wizards, dragons, princesses, all sorts of things. Where's Wally put in an appearance as well. But I hope you can pick up from the photo, although in theory Party Week was about the kids and celebrating or making hospital a bit different and a bit fun for the kids, for me it was actually really about the staff team, and we had the most fantastic enjoyable week, and I can't underestimate the value of that for building our team. And so if you're not already doing Party Week in your children's ward, I want to recommend it. So on to the proper talk now. General paediatrics, very common reason that people consult us is the irritable, unsettled baby. Often okay for the first couple of weeks, and then they come to us about 6 to 8 weeks crying, irritable. We've got stressed, exhausted parents who've been consulting the Dr. Google and their internet mothers groups and things, and being told various things like, oh, could he have tongue tie? And a whole lot of them will be saying, oh, it sounds like reflux, go and see your doctor and get some medication. And when I'm faced with that sort of baby, I'm aware that the evidence for acid suppressing medications in those babies having any benefit or effect is non-existent, and we've got sort of a growing body of evidence that PPIs in particular may cause harm. So I think this study I'm talking about here is relevant from the point of view of kind of adding to my bucket of tools that I use when I'm talking to families about why really what I want them to do with their unsettled baby is hang in there and know that it's going to get better rather than jump in with medical treatment. So this article was published earlier this year. It's a big retrospective cohort study from one of the American health organisations, I think they're called TRICARE, who look after healthcare for all uniformed military personnel in the United States. So it's a huge database. And they analysed more than 10 years worth of data. So they've gone from 2001 to 2013, and then they've spent the next few years analysing the data before publishing this study. And what they looked at were children who were prescribed acid-suppressing medications, so either H2 receptor antagonists or proton pump inhibitors, or antibiotics during the first 6 months of life. And then they followed them to see if they subsequently developed allergic conditions during early childhood. And the sorts of conditions they were looking at were food allergy, anaphylaxis, asthma, atopic dermatitis, urticaria, allergic rhinitis. And because of the way that the healthcare system works there, they've got detailed records on all these kids. So if any scripts were dispensed, they'd have a record, and if there were any health encounters related to allergic disease. There was some kids were excluded, and those were kids whose initial hospital birth length of stay was more than 7 days. So I think that probably rules out any babies with significant prematurity. And they also excluded kids who developed allergic disease in the first 6 months of life. And they needed to have at least 12 months of data for the kid to be included in the study. But as I said, they were looking over 13 years worth of data. So they had many years of data for some kids, and the median length of time they had data for was 5 years. So you can see from the slide there, they found, about 10% of kids were prescribed acid-suppressing medications, and 16% were prescribed antibiotics during that first 6 months of life. And both groups had an increased incidence of childhood allergic disease. The effect was most marked with the acid-suppressing medications and was sort of dose-dependent in that it was more likely with PPIs than H2 receptor antagonists, and the longer you were on a PPI for, the more likely you were to develop allergic disease. And putting it in a ballpark, it was for between 2 and 2.5 times more likely that you would develop allergic disease. And for the PPIs and the H2 receptor antagonists, it was particularly food allergy that was increased, cow's milk allergy being the most common, and then peanut and egg. Some caveat or caution, which is this study definitely showed correlation, but we know that correlation doesn't equal causation, and more work will need to be done to try and unpick and untangle that. The sort of theory or hypothesis behind this is, I think, to do with the gut microbiome being changed. And if you think about the effect of PPIs in particular, where you've got basically no gastric acid being produced, that's going to affect your gut microbiome. There's also the theoretical thing that the protein molecules are less broken down and less digested before they reach the lower gut and perhaps more antigenic. But I feel as though this article gives me a little bit more ammunition when I'm dealing with that stressed, anxious family who are desperately seeking medication, who it's really hard because I certainly sometimes feel as though if I don't prescribe for them, they're going to doctor shop until they find someone who will prescribe. So next study I looked at was one from late last year comparing Betalactam monotherapy, so basically your penicillin, ampicillin, cephalosporin treatment for children admitted to hospital with community-acquired pneumonia, versus Betalactam plus adding on a Macrolide. Most commonly in the study it was azithromycin. And the reason this is of interest to me is the people who've worked for me will be well aware that most of the time when I have someone, say 4 and up, admitted under my care with community-acquired pneumonia, more often than not I will put them on azithromycin as well as benzoyl penicillin or whatever else they're getting to cover for mycoplasma. So this one was a prospective cohort study of over 1,400 children. Just over 1,000 of them had the Betalactam monotherapy and 400 of them got the Macrolide as well. This was part of another bigger pneumonia study they were doing, where there was a fairly robust methodology where the pneumonias were radiologically confirmed, and they also looked for causative agents. So they did viral studies and bacterial studies as well as mycoplasma type things, and what they found was that at least 70% of the time there was a viral agent identified. A small amount of the time they showed mycoplasma or a bacterial pathogen. And basically the outcome of the study is there is no added benefit of adding the Macrolide, and that even included the group of kids who had confirmed mycoplasma infection. And the stuff they were looking at was the length of stay, the outcome measure they were looking at was the length of stay in hospital, and they also did things like ICU admission. They did follow-up phone calls to check on recovery time and period, and really they showed no difference. So I should change my practice. So the next paper I want to talk about is a little bit different. This one is written by 3 parents of children with chronic and complex medical conditions, and they sent out 735 questionnaires to other parents of children with chronic and complex conditions. And they came up with a top 10 things that they want us as their treating doctors to know. I'm not going to read these out, and this wonderful infographic was done by Grace, and that's available on the Don't Forget the Bubbles website. But a couple of things to highlight. Related to this, and I think we heard about it on Monday with Scott and Joanne talking about their NICU parent journey. When we're treating a child with chronic and complex illness, we're not just treating the child, we're treating the family. And we need to get to know the child and their family and to understand what is difficult for them and what is stressful for them, and do what we can to relieve that stress. Along the same lines, I looked at some papers, and I didn't have time to actually put them in, which talk about what do parents want to be called when we're doing ward rounds or seeing kids in clinic. What do they want us to call them? And I think the answer is basically they want us to call them by name. But if you don't know their name, the terms mum or dad are more acceptable than the terms mummy or daddy. I think that's quite American. I'm not sure that we do that much here, but don't call them mummy or daddy. And they also hate ma'am and sir. So the name is the best, but if you don't know the name mum or dad, and when you're trying to get to know the name, don't make the assumption that the mother's surname in particular is the same as the child's surname. And so try and develop tricks for remembering their names. I have, when I do clinic, I call it my cheat sheet, which is where I will draw a pedigree and put everyone's names on the back of that front sheet, so that I can refer to that when I'm thinking, I really can't remember your name, you know, and rather than call you Jamie's mum, I need to try and get to know their name. And the other thing I wanted to highlight from this paper was the plea from the parents that we coordinate their appointments where possible. They often have multiple specialists involved in their care and multiple appointments, and it reduces the stress if we coordinate their appointments. So, on a lighter note, the majority of us, I think, are involved in teaching, particularly medical students, but all sorts of teaching. And for some of us, if we're employed by the universities, the teaching evaluations are actually considered very important in terms of both maintaining our employment but also for career progression. And this study was done in Germany with German medical students. It was a prospective randomised controlled trial with, from my reading of the paper, reasonably robust methodology. So it's a group of about 200 medical students. They were divided into 20 groups to have the teaching session. It was a case-based discussion as part of their emergency medicine course where they would be discussing acute coronary syndrome, presented with a case, and then go through and discuss the case. There were 2 teachers, so each teacher had 10 groups of students, and in those groups of 10, half the groups were given cookies during the teaching session and the other half weren't. There were plenty of cookies, and the teachers were just told to say, I bought some cookies, and that they could take the first cookie to try and break down so that the students didn't feel as though they couldn't eat them. They weighed the number of cookies that were left at the end of the session and all sorts of things. But in a nutshell, if you have cookies at your teaching session, both the quality of the delivery, so the teacher, and the quality of the content were consistently evaluated higher. So have cookies for your teaching session. So the last paper I want to present is very relevant to our unit, and I think it also reflects the power of social media, in that the reason this is relevant to our unit is one of our anaesthetists read about or heard about this paper on Twitter earlier this year, and that started for us a process of applying to get toy cars for our kids. So it's a study that was done in China, prospective randomised controlled trial, where they randomised the children to 3 groups. So one group went to the operating theatre in the ride-on car, the other group went on the hospital gurney, just standard way you would do it, and the third group went on the hospital gurney but were also given a dose of oral midazolam when they reached the sort of theatre waiting or holding area where the child would usually be there for half an hour before their procedure. They measured or recorded anxiety in the children at multiple different time points along this theatre journey. They excluded children who'd already had surgical procedures or been to theatre before, so the only children in the study, this was their first trip to theatre. And they got the parents to do a visual analogue scale of anxiety, and then they also used a validated short form, I can't remember the name of it, sorry, from Yale University, but basically a validated anxiety score, and it was recorded at the pre-op visit with the anaesthetist, then as they went into the car onto the gurney, then when they arrived in the theatre holding bay, then when they were going from the holding bay into the operating theatre, and that's the point at which they were separated from their parents, and then on induction of anaesthesia. And what they showed was that going to theatre in the toy car is as good as having midazolam for pre-operative anxiolysis. And so for us, that culminated in the delivery last Friday of our 2 cars. So the Captain Convoy came to our ward and delivered a Mercedes-Benz and a Ford Ranger. And so the children can choose which car they want to go to theatre in. The cars are remote controlled, so the wardsman from theatre will drive the car up, pick up the child and then drive them back, sort of, travelling behind them using the remote control to drive them. And I've seen something this morning saying the first kid went to theatre in the car earlier this week. So I know that's only a small study, but I thought it was highly relevant, and it showed that our anaesthetist heard about it on social media. And that's all.